Welcome to this comprehensive lecture on chronic suppurative lung disease in children, presented by Pediatric Case Review. Today, we will explore the clinical presentation, examination findings, pathophysiology, investigations, treatment approaches, and complications of this important respiratory condition. This lecture includes 14 case-based questions to enhance your clinical knowledge and prepare you for real-world scenarios. Chronic suppurative lung disease represents a spectrum of conditions characterized by persistent airway infection and inflammation. Early recognition and appropriate management are crucial to prevent progression to irreversible bronchiectasis. Let us begin our educational journey through this complex pediatric respiratory disorder. Question 1. A 2-year-old child presents with a daily wet cough lasting 8 weeks. There is no fever, and the cough shows poor response to inhaled bronchodilators. What is the most likely diagnosis? Option A, protracted bacterial bronchitis. Option B, uncontrolled asthma. Option C, habit cough. Option D, gastroesophageal reflux disease. Take a moment to consider the clinical features presented. The key elements here are the child's age, the duration of wet cough exceeding 4 weeks, absence of fever, and lack of response to bronchodilators. Wet cough in young children typically indicates secretions in the airways rather than bronchospasm. The correct answer is A, protracted bacterial bronchitis. This diagnosis is most likely given the chronic wet cough lasting more than 4 weeks in a young child, the age of presentation typically between 1 and 6 years, and poor response to bronchodilators, which suggests bacterial etiology rather than asthmatic disease. Protracted bacterial bronchitis is defined by wet cough lasting over 4 weeks that responds to antibiotics. Option B is incorrect because asthma typically presents with dry cough, variable wheeze, and response to bronchodilators. Options C and D lack the typical clinical features. Habit cough is usually dry and disappears during sleep, while reflux disease presents with additional gastrointestinal symptoms. Question 2. A 6-year-old child presents with daily wet cough and minimal wheeze. The cough shows poor response to inhaled corticosteroid therapy over several months. What is the best feature distinguishing this presentation from asthma? Option A, family history of atopy. Option B, daily wet cough with antibiotic response. Option C, night-only dry cough. Option D, exercise-induced breathlessness only. Consider which clinical feature specifically points toward chronic suppurative airway disease rather than asthma. The quality of the cough and treatment response patterns are critical distinguishing factors in pediatric respiratory conditions. The correct answer is B, daily wet cough with antibiotic response. This feature strongly points to chronic suppurative airway disease rather than asthma. Wet cough suggests infection and retains secretions in the airways, which respond to antibiotic therapy targeting bacterial pathogens. The lack of response to inhaled corticosteroids further supports a non-asthmatic etiology. Options A, C, and D are either non-specific findings or actually suggest asthma rather than chronic suppurative lung disease. Family history of atopy supports asthma. Night-only dry cough and exercise-induced symptoms are classic asthmatic presentations. The antibiotic responsiveness combined with wet cough quality is the key distinguishing feature. Question 3. A 7-year-old child presents with recurrent chest infections and growth faltering over the past 2 years. On chest examination, what is the most characteristic finding? Option A, fine apical crackles only. Option B, localized monophonic wheeze. Option C, generalized hyperresonance. Option D, coarse inspiratory crackles at the bases that partly clear with cough. Think about the pathophysiology of chronic suppurative lung disease. What physical examination findings would you expect with retained secretions and dilated airways? The character and location of abnormal breath sounds provide important diagnostic clues in pediatric respiratory disease. The correct answer is D, coarse inspiratory crackles at the bases that partly clear with cough. These crackles reflect retained secretions and airway dilation characteristic of chronic suppurative lung disease and bronchiectasis. The coarse quality indicates larger airway involvement, and partial clearing with cough demonstrates mobile secretions. Basal predominance is typical due to gravitational effects. Option A, fine apical crackles, suggests interstitial lung disease like hypersensitivity pneumonitis. Option B, localized monophonic wheeze, should make us think of foreign body aspiration or endobronchial lesion. Option C, generalized hyperresonance, suggests obstructive hyperinflation alone without the suppurative component that characterizes this disease. Question 4. An 11-year-old child has had wet cough for several years. Physical examination now reveals digital clubbing. Digital clubbing most suggests which condition? Option A, acute viral bronchiolitis. Option B, severe chronic suppurative lung disease. Option C, allergic rhinitis. Option D, simple gastroesophageal reflux. Digital clubbing is an important physical examination finding that indicates chronicity and severity of underlying disease. Consider which conditions cause prolonged hypoxia and chronic inflammation sufficient to produce this sign. The presence of clubbing significantly changes clinical management and prognosis. The correct answer is B, severe chronic suppurative lung disease. Digital clubbing develops due to chronic hypoxia and persistent inflammation seen in advanced bronchiectasis or severe chronic suppurative lung disease. The pathophysiology involves increased blood flow to fingertips and proliferation of connective tissue at nail beds. Clubbing indicates long-standing disease, typically present for months to years. Options A, C, and D do not cause digital clubbing. Acute viral bronchiolitis is self-limited. Allergic rhinitis affects upper airways without systemic effects. Simple reflux does not cause chronic hypoxia. The presence of clubbing indicates more severe and long-standing respiratory disease requiring thorough investigation and aggressive management to prevent further deterioration. Question 5. A child experiences recurrent bacterial exacerbations despite treatment attempts. What is the correct sequence of the vicious cycle in chronic suppurative lung disease pathophysiology? Option A, infection leads to inflammation, then impaired clearance, then damage. Option B, damage leads to impaired clearance, then infection, then inflammation. Option C, impaired clearance leads to infection, then neutrophilic inflammation, then airway damage. Option D, inflammation leads to damage, clearance improves, infection resolved. Understanding the vicious cycle is fundamental to comprehending disease progression and identifying therapeutic targets. Each step in this cycle perpetuates the next. The correct answer is C, impaired clearance leads to infection, then neutrophilic inflammation, then airway damage. This sequence accurately explains disease progression and identifies targets for therapeutic intervention. Impaired mucociliary clearance, whether from congenital defects, viral injury, or aspiration, allows bacterial colonization. Persistent bacteria trigger intense neutrophilic inflammation, releasing proteases and causing progressive airway damage. This damage further impairs clearance, perpetuating the cycle. Understanding this mechanism guides treatment. Enhance clearance with physiotherapy, eradicate infection with antibiotics, and intervene early to prevent irreversible damage. The other options present incorrect sequences or incorrect physiology. Breaking this vicious cycle requires multimodal therapy addressing each component simultaneously. Question 6. An 8-year-old child with persistent wet cough and recurrent infections requires imaging confirmation of suspected bronchiectasis. What is the best imaging criterion supporting bronchiectasis diagnosis in a child? Option A, tree and bud pattern alone. Option B, airway to artery ratio above age-adjusted threshold with lack of tapering. Option C, mosaic attenuation alone. Option D, mucus plugging alone. High-resolution computed tomography is the gold standard for diagnosing bronchiectasis. However, diagnostic criteria differ between children and adults. Understanding pediatric-specific criteria is essential for accurate diagnosis. The correct answer is B, airway to artery ratio above age-adjusted threshold with lack of tapering. Pediatric criteria for bronchiectasis differ significantly from adult criteria and must account for age-related variations in normal anatomy. Children have smaller airways with lower normal bronchoarterial ratios. Bronchiectasis diagnosis requires demonstration of actual airway dilation, defined as increased airway to artery ratio beyond age-appropriate norms, accompanied by lack of normal bronchial tapering. Options A, C, and D represent important but non-specific findings. Tree and bud pattern indicates small airway inflammation but not necessarily dilation. Mosaic attenuation suggests air trapping. Mucus plugging occurs in many conditions. None of these alone demonstrates the structural airway dilation required for bronchiectasis diagnosis. Question 7. A 12-year-old child undergoes high-resolution computed tomography scan review for suspected bronchiectasis. Which statement about bronchoarterial ratio measurement is true? Option A, normal ratio is greater than 1.0 in older children. Option B, ratio greater than 0.8 is abnormal in older children. Option C, ratio greater than 1.5 is required in all ages for diagnosis. Option D, ratio thresholds are identical to adults. Accurate interpretation of pediatric chest imaging requires knowledge of age-specific normal values. Using adult criteria in children leads to diagnostic errors. The correct answer is B. Ratio greater than 0.8 is abnormal in older children. Age-adjusted pediatric thresholds are essential for accurate bronchiectasis diagnosis. In preschool children, normal bronchoarterial ratio is typically less than 0.5. In older children and adolescents, the upper limit of normal is approximately 0.8, significantly lower than the adult threshold of 1.0 to 1.5. Options A, C, and D reflect adult criteria or incorrect values. Applying adult diagnostic thresholds to pediatric patients results in underdiagnosis of bronchiectasis. Airways in children are proportionally smaller relative to adjacent vessels. Using age-inappropriate criteria misses early disease when intervention is most effective. Always apply pediatric-specific diagnostic criteria. Question 8. A 5-year-old child presents with chronic suppurative lung disease features, but no known underlying cause has been identified. What is the most appropriate first-line etiologic panel for investigating underlying causes? Option A, allergy skin testing only. Option B, sweat test plus quantitative immunoglobulins plus vaccine antibody responses plus airway culture. Option C, lung biopsy first. Option D, comprehensive genetic panel only. Systematic investigation is essential to identify treatable underlying causes. The workup should be comprehensive yet proceed from non-invasive to invasive testing. The correct answer is B, comprehensive non-invasive tests first, including sweat test, quantitative immunoglobulins, vaccine antibody responses, and airway cultures. This panel systematically rules out cystic fibrosis with sweat chloride testing, identifies immune deficiency with immunoglobulin levels and specific antibody responses to vaccines, and identifies causative pathogens through airway cultures. This approach is evidence-based and cost-effective. Options A, C, and D are incomplete, too invasive, or premature. Allergy testing alone misses important diagnoses. Lung biopsy carries risks and should be reserved for cases where non-invasive testing is inconclusive. Genetic panels are expensive and should be targeted based on clinical suspicion. A systematic non-invasive approach identifies most underlying causes before considering invasive procedures. Question 9. A 6-year-old child with established bronchiectasis presents with increased wet cough, purulent sputum production, and new crackles on chest examination consistent with acute exacerbation. What is the recommended oral antibiotic duration for treating this exacerbation? Option A, 5 days. Option B, 7 days. Option C, 10 days. Option D, 14 days. Appropriate antibiotic duration is crucial for successful eradication of infection in children with bronchiectasis. Exacerbations require longer treatment than typical community-acquired pneumonia due to underlying airway disease. The correct answer is D, 14 days. Recent pediatric guidelines support at least 14 days of antibiotics for exacerbations of chronic suppurative lung disease and bronchiectasis. This duration is longer than typical pneumonia treatment due to impaired clearance mechanisms, bacterial biofilm formation in damaged airways, and need for complete eradication to prevent rapid recurrence. Studies demonstrate higher failure rates with shorter courses. Some children require even longer treatment, particularly those with Pseudomonas infection or severe underlying disease. The 14-day minimum represents current evidence-based practice. Inadequate treatment duration leads to persistent infection, repeated courses of antibiotics, antibiotic resistance development, and progressive lung damage. Extended duration improves outcomes and reduces exacerbation frequency. Question 10. A 9-year-old child with bronchiectasis has experienced 4 exacerbations requiring antibiotics in the past 12 months despite regular airway clearance physiotherapy and appropriate acute treatment. What is the best next step in management? Option A, start long-term azithromycin after exclusion of non-tuberculous mycobacteria. Option B, increase inhaled corticosteroid dose only. Option C, no change, just continue observing. Option D, proceed directly to immediate surgical resection. Frequent exacerbations despite optimal management require consideration of prophylactic strategies. Evidence supports specific interventions for reducing exacerbation frequency. The correct answer is A, start long-term azithromycin after appropriate screening for non-tuberculous mycobacteria. Strong evidence from randomized controlled trials demonstrates that long-term azithromycin prophylaxis reduces exacerbation frequency in children with frequent relapses. The mechanism involves both antimicrobial effects and anti-inflammatory properties. Screening for non-tuberculous mycobacteria before starting is essential to avoid developing macrolide resistance in undetected mycobacterial infection. Typical dosing is 3 times weekly. Options B and C are inadequate for this level of disease activity. Inhaled corticosteroids lack evidence in non-cystic fibrosis bronchiectasis. Observation allows continued lung damage. Option D, surgery, is not indicated as first line for diffuse disease with multiple exacerbations. Surgery is reserved for localized disease unresponsive to medical management. Question 11. An 8-year-old child with bronchiectasis is struggling with daily sputum clearance despite good medication compliance. What is the most appropriate airway clearance technique for this age group? Option A, bed rest only. Option B, active cycle of breathing techniques with positive expiratory pressure devices. Option C, no physiotherapy, rely only on antibiotics. Option D, routine bronchoscopy for suction. Airway clearance is a cornerstone of bronchiectasis management. Age-appropriate techniques maximize effectiveness while ensuring patient compliance. The correct answer is B, active cycle of breathing techniques with positive expiratory pressure devices under physiotherapy guidance. These techniques are age-appropriate, evidence-based, and effective for school-age children. Active cycle of breathing combines breathing control, thoracic expansion exercises, and forced expiration technique. Positive expiratory pressure devices help maintain airway patency and mobilize secretions. Physiotherapist instruction ensures proper technique. Option A, bed rest, is ineffective and may worsen secretion retention through reduced activity and gravitational pooling. Option C ignores the fundamental importance of mechanical clearance. Antibiotics treat infection but do not remove secretions. Option D, routine bronchoscopy, is too invasive for daily management. Bronchoscopy is reserved for mucus plugging unresponsive to non-invasive techniques or diagnostic sampling. Question 12. A 10-year-old child with bronchiectasis has new Pseudomonas aeruginosa isolated in sputum culture for the first time. What is the clinical significance of this microbiological finding? Option A, benign colonizer requiring no action whatsoever. Option B, associated with faster lung function decline and worse morbidity, therefore attempt eradication. Option C, always represents contamination only. Option D, indicates viral infection. Pseudomonas aeruginosa is an important pathogen in bronchiectasis with significant implications for prognosis and management. Early detection and appropriate response are crucial. The correct answer is B. Pseudomonas aeruginosa is associated with faster lung function decline and worse morbidity, and eradication should be attempted upon first isolation. Multiple studies demonstrate that Pseudomonas colonization correlates with accelerated disease progression, more frequent exacerbations, greater lung function decline, and worse quality of life in both children and adults with bronchiectasis. First isolation represents an opportunity for eradication before chronic infection establishes. Eradication protocols typically include combination antibiotics, sometimes with inhaled tobramycin. Options A and C incorrectly minimize its importance. Pseudomonas is never benign in bronchiectasis, and true infection must be distinguished from contamination by repeat culture. Option D is incorrect. Pseudomonas is bacterial. Aggressive early treatment improves long-term outcomes. Question 13. A 4-year-old child with non-cystic fibrosis chronic suppurative lung disease presents with an acute exacerbation requiring antibiotic therapy. What are the most likely bacterial pathogens causing this exacerbation? Option A, non-typable Haemophilus influenza, Streptococcus pneumoniae, Moraxella catarrhalis. Option B, Legionella and Chlamydia psittaci. Option C, Mycoplasma exclusively. Option D, anaerobes only. Knowledge of typical pathogens guides appropriate empiric antibiotic selection while awaiting culture results. Pathogen profiles differ between cystic fibrosis and non-cystic fibrosis bronchiectasis. The correct answer is A. The most common bacterial pathogens are non-typable Haemophilus influenza, Streptococcus pneumoniae, and Moraxella catarrhalis. These represent typical community respiratory bacteria and are most frequently isolated from bronchoalveolar lavage and sputum cultures in children with non-cystic fibrosis chronic suppurative lung disease and bronchiectasis. This knowledge informs empiric antibiotic selection favoring agents like amoxicillin clavulinate with activity against these organisms. Options B, C, and D represent less common pathogens in this clinical setting. Legionella and Chlamydia psittaci are rare. Mycoplasma causes atypical pneumonia but not chronic suppuration. Anaerobes occur mainly with aspiration or lung abscess. Appropriate empiric antibiotics should target the common triad of pathogens. Question 14. A 12-year-old child presents with established bronchiectasis. History reveals 6 episodes of pneumonia requiring hospitalization before age 5 years. and the family lives in crowded housing with multiple occupants. What is the strongest risk factor for bronchiectasis development in this clinical scenario? Option A, single mild wheezing illness in infancy. Option B, recurrent severe pneumonias in early childhood. Option C, seasonal allergies. Option D, excess screen time. Understanding risk factors helps identify children at high risk who require close monitoring and early intervention. The correct answer is B, recurrent severe pneumonias in early childhood represent the strongest risk factor. There is a clear dose-response relationship between number and severity of early childhood pneumonias and later development of bronchiectasis. Case control studies demonstrate that children with 4 to 5 pneumonias have 3 times higher risk, while those with 6 or more have 21 times higher risk of developing bronchiectasis. Early childhood represents a critical window when lungs are developing and particularly vulnerable to injury. Options A, C, and D are not established risk factors for bronchiectasis. Single mild illness does not cause chronic damage. Allergies and screen time lack association with structural lung disease. Prevention through vaccination, early pneumonia treatment, and addressing social determinants of health is crucial. Join our Pediatric Case review community on Patreon for exclusive educational resources. In this exclusive community, all our educational videos are carefully arranged by organ system, making it easy to access all content in one organized place. This systematic organization helps you learn efficiently and review topics comprehensively. Plus, all presentations used in the videos are available as downloadable high-resolution images, allowing you to read and practice all questions at your own pace. Review key concepts anytime and create your own study materials. For complete details about membership benefits, subscription options, and how to join our growing learning community, comment below in this post, and we will message you directly with all information. In conclusion, the key takeaway from this comprehensive lecture is to recognize chronic wet cough early in children, investigate thoroughly to identify the underlying cause, and treat promptly to prevent progression to irreversible bronchiectasis. Early intervention is critical for preserving lung function and preventing long-term complications. Remember the vicious cycle of impaired clearance, infection, inflammation, and damage. Break this cycle through airway clearance, appropriate antibiotics, and addressing underlying causes. Follow Pediatric Case Review on YouTube for more informative presentations covering all aspects of pediatric medicine. If you have any questions about chronic suppurative lung disease, protracted bacterial bronchitis, or bronchiectasis management, please comment below. Thank you for watching and continuing your medical education journey with us.